Hi everyone, thank you so much for signing up to Dr. Geoffrey Rosenberg's seminar today on the topic of the difference between someone with a DRE I, II, and III cervical spine injury and lumbar spine, and how that translates into whole person impairment percentage. So during the presentation, the attendees will be muted to avoid any random noises that might distract the presenter. So today we have Dr. Rosenberg. He's completed orthopedic training in the UK and Sydney. His major interest is spinal surgery, primarily adult degenerative spinal conditions, and this includes reconstruction, arthroplasty, and minimally invasive surgery. He also performs robotic spinal surgery, arthroplasty of hip and knee, and arthroscopy. So thank you, Dr. Rosenberg, for this today.
All right. Hello. Good morning, good afternoon, good evening, whenever you might be watching it. So my name's Geoff Rosenberg. I've been working with the MAG group for about 6 years. I primarily do spinal surgery, but my generation, we like to think we have knowledge about a wide variety of orthopaedic issues. So I thought these guys liked me. I had hoped some of you people listening in liked me because this seems a very dry topic. It's all about the DRE classification system. With spine, it's really black and white, as opposed to upper limb and lower limb. So we're not interested in range of movement. We're not interested in pain. Well, we are, but we're not because it's so subjective. So how do you measure it? It's really, you fall into diagnostic related groups. And it took me a while to come to grips with it, but now I do, and I think it's a very good system. I think it's a very fair system. Can we just go to the next slide, please, Sophia? So I primarily do spine surgery, and part of the reason I got into the medico-legal side of things was I saw a lot of reports from experts who had never done spine surgery, and their interpretations were different from mine. And I think it does make a difference if you actually are an experienced spine surgeon or you don't do or haven't done any for many years. Because I think certainly I believe as a spine surgeon, there's a deeper understanding and expertise and experience. So you tend to award a higher rating. So I don't think I've ever awarded anyone a DRE category 5 because I've just not seen anyone. But spine is one of those weird things where if you have an operation, you're instantly in a higher group. So if you had a fusion, you're in DRE 4. So there's plenty of that awarded, and it's black and white. They give you a small range between 20 and 23%. With cervical spine, it's a bit higher. It is between 25 and 28%. But usually you start off at the lowest and then you add that leeway for how it affects their activities of daily living. Spine is the only one of all these ratings where ADLs matter. They might matter to the patient if they've got a problem with their leg or with their arm, but they're not a rateable impairment applicable in this world unless it's a primary spinal condition. So a lot of people come in howling the house down in pain, but pain itself is just, it's a very subjective thing. So myself and Sophia might have the same injury and she's tough and stoic, whereas I'm lying there in the fetal position screaming. So pain ranks nothing. So a lot of people say, my back hurts, I've got this, I've got that, there's no real injury, it just came on, they've got, non-dermatomal leg pain, there's no suggestion of anything. And often you've got x-rays, etc., to rely on, and well, disappointingly for them, you have near normal scans and yet they're in agony. So they might be in pain and they're genuine. It's not to suggest that they're not, but they just rank a DRE 1, which is 0%. Pain and nothing else doesn't rate. And it's the same in the thoracic spine and it's the same in the cervical spine. Moving along, DRE category 2, this is people who have historically, you think they might have some, like they've usually had an injury. They've had one specific injury, not always, but usually. They've got well, let's stick to lumbar spine. They've got back pain and they've got leg pain as well. And always as the clinician, you're trying to get a gauge of which level in the spine, if it's a disc, it might be. And by that, I mean where the pain goes down the leg. So classically, pain in the buttock usually is L4-5, sometimes can be lumbosacral. Pain down the side or back of the thigh could be either of those. Pain to the front of the knee usually is L4, but not always. So usually that's an L3-4 problem. Pain down the shin is L4. Pain on the outside of the calf is L5. Pain to the top of the foot and the big toe is L5. Pain underneath the foot or to the side is S1. These are not absolutes, but they're just rough guides. They're rough guides. Often they might have, if not pain, they might have dysesthesias, they might have numbness, they might have tingling, they might have pins and needles. And often they're terrified that this represents, so they're about to be paralyzed. When something's irritating the nerve, you get inflammation and swelling around the nerves. You cannot see it on scans, you can't see it on the patients, but it's there. So from my side of the desk, it means that there's something, disc, bone, irritating the nerve. And if it continues, it becomes painful. So, you know, in DRE lumbar category 2, they say non-verifiable radicular complaints. And I take that to mean, yes, they have leg pain, but it's not in any particular dermatome or not affecting any particular muscle growth, meaning a myotome, but they are genuine. It doesn't quite tick the box for radiculopathy, and I'll come back to that point in a sec, but usually they've had a discrete injury, they've had back pain, they've got leg pain, they talk about dysmetria, loss of range of motion. They just, you know, they're obviously struggling. They don't have full flexion, they barely get down to their knees, they might climb up their thighs. You know, and once again, you try to be kind. Most of these people you're seeing are quite genuine. Just to that point about radiculopathy, they're quite strict that you've got to have either loss or asymmetry of reflexes, muscle weakness. So classically a 4-5 disc squishing the L5 nerve root. They will have loss, if it's bad enough, loss of strength of dorsiflexion of the foot and the toes, particularly EHL, big toe. And often they'll be weak in their glutes. And the simplest way to test that is get them to do a Trendelenburg. They single leg stance and the hip sags down. That doesn't mean you've got an arthritic hip. It can also mean in this world you've got a disc or something impinging the L5 nerve root. That you've got loss of sensation, positive straight leg raise, muscle wasting in the expected group, and findings on imaging. So you need 2 or more of them. You don't have to have all of them to tick the box. So conversely, you can see people who've got a normal MRI, and yet for all the world, you're expecting to see a big fat disc protrusion and you don't see it. So part of the explanation of that is, I suspect that it's because the MRI is taken supine and you're not seeing standing or bending MRI when the disc may be protruding further. So then you trundle along to DRE lumbar category 3, where now you've got someone who gives a good story. They've got back pain, they've got leg pain, they've had an injury, they've got a positive straight leg raise, meaning not that their back hurts, but they get reproducible leg pain down the back of their thigh when you're elevating them. Sometimes you've got to be careful because I do a straight leg raise when they're sitting and when they're lying down. And when they're sitting over the bed, often they can extend their knee 90, but on the bed they can't. And it's not because they're malingering, it's just they're lying down and their back is really, really sore. They may have weakness, they may have loss of reflexes, they may have altered sensation to light touch or pinprick, and then you're seeing something on the MRI scan that explains that. So, you know, they instantly become a 10% whole person impairment. The way you then are meant to apply it is that you then add the loss of activities of daily living. I've never given anyone a 3%, not because I'm harsh, but I've never seen anyone that bad, because 3% means that you can't even attend to personal care. So if they can wash themselves, they're coming in clean, presented and whatever, you know, straight away, that's 1% that's not affected. 2%, they can't help around the house much. They can't do vacuuming, hanging out the washing, and 3% they can't do any outside yard work. They have to pay someone to come and mow the lawns, stuff like that. So you add that. So say they can't mow the lawns and they can't help around the house, but they can clean themselves. 10 plus 2 equals 12%. Okay. So then the next thing is, are there deductions for pre-existing abnormalities? So classically, they may have had a disc operation or a disc problem in the past at the same level. And they always say, yes, and I've been perfectly well ever since. And most of them have been. And now it's a new frank injury or incident. And yet, if their twin brother had the same problem but didn't have the prior issue with their disc, there's no deductible deduction necessary. But with them, it is, I believe. A standard thing is awards start at 10%. So say we've just given this punter a 12% WPI. 12 minus 1.2 equals 10.8, and you round it up. So it's 11%. But it's your discretion. I've given plenty of time, so I've done a 50% deduction for pre-existing things based on their story, their radiology, what you find, stuff like that. So 12 minus 50 is 6, and that's a 6% WPI. Then to do with spinal conditions as well, and it's the only one, you've got the modifiers. So I'm talking Cira Guide's 4th edition for work cover. You've got modifiers. Interestingly, for AMA 4, which in this state is for motor vehicle accidents, there's no application for ADLs. Okay, it's just not part of the system. But you've got modifiers on page 29, table 4.2, and this is relevant to if they've had surgery. So if someone's had a 2-level discectomy, okay, so you've got your, say, 12% WPI because they've had a disc protrusion and they've got, and they may have, if you read it, they may have had an operation already that did or didn't help, but that's where the modifiers come in. So spinal surgery with residual symptoms. So they've had a discectomy, but they've still got their pain. Not that their back is sore, but they've got symptoms that tick the box for ridiculous symptoms. That's an extra 3%. If you've done a 2-level, you add 1% for each additional level. If they needed another operation because they had a recurrent disc, that's another 2%. And so it goes. So you've got your WPI plus your ADL, and that gives you a figure, which we're saying is 12%. Then with the modifiers, you combine these using the tables at the back of the AMA guides. But these are low numbers, so they're pretty well adding and combining are almost the same, if not the same. And then you combine those two. So if with modifiers, I have an extra, he's got residual, or he or she's got residual symptoms, a second and further level, and a second operation. So we're combining, says he, going to the table, 3, and you always start at the highest, combining with the next one down. 3 combined with 2 is 5, 5 combined with 2 is 1, which is the same as if you're adding them 6. So then you combine the 12 with the 6, okay? And 12 combining with 6 is not 18, it's 17%, okay? So you do that. And then that's where you do a deduction for pre-existing problems. But so after a while, you get quite used to it. Anyone who's had an operation shaving a disc in the neck or in the back or having a laminectomy for decompression, instantly you're a DRE I-III. If you've had a fusion, you're a DRE IV, land of milk and honey, because you start off at 20%. Okay, so this is the way you apply it. I truly believe that as a spine surgeon, you have a deeper, well, you do have more experience, and you're far more likely to assign someone DRE I-III as opposed to DRE II. I'm not saying that to be inflammatory, but that's my personal experience. You always try to believe, well, you do believe them, and you always try and assign the highest grade that you can, being fair. The main way you get trapped out is have you had any problems before? Never. Well, why did you have a CT scan of your back 5 years ago? Oh, that was nothing. So that's not that you're trying to trap people, but that's where they sometimes come undone. Can we have a look at the, yeah. So like anything with these examinations, The symptoms are paramount. I particularly, try and get the most accurate history I can. And that's the other thing is half the time when you injure your back or injure your neck, it's a discrete accident. Oh, I wish I'd waited for help, but I didn't. I was impatient. I lifted this thing, felt a pop in my back, and I've had trouble ever since. And the other half of the time, there is no one discrete incident. It just starts the nature and conditions of their job. Not sitting at a desk, but, heavy physical work. Signs, often the signs, they're near normal. There are no signs. Their straight leg raise causes back pain, but you don't find any weakness or abnormality in their reflexes or loss of sensation. So then you go to the imaging, and often the imaging, the MRI does not lie. A CT is not a bad place to start, but because it's readily available and tends to be bulk billed, these poor people get CT after CT after CT. Someone's got to pay for this. And similarly with the MRIs, a lot of my colleagues choose to monitor their patients. Well, even if you're well, come back in a year and let's see how you're doing. Let's get an MRI. It doesn't matter. Treat the man, not the scan. But in this medico-legal, sort of in the firing line as a spine surgeon in my clinical practice, by and large, if I don't see the imaging, it doesn't exist. When I'm doing medico-legal consulting, I'm not quite as strict, but I can access most of them. But you do prefer to see it, as certainly as a treating doctor, and just to give the most complete thing. It's not that I'm so arrogant I know everything. I miss things, but so do they. Can we go to the next slide, please? Yes, as I said before, pain scores nothing. So they might have agony, they may be genuine, they may be not, but it doesn't rate anything. A big fat 0. Is that my life? Well, this is the tables. I can't even begin to read that. Neither can you. I just put it up there, but that's basically the go-to for cervical and for lumbar spine. Hang on, look at that misprint. There it is. Go back. Look at DRE I-III for cervical. It says DRE lumbar. Just pick that. There you go. We better keep stum about that. I'm sure it's a typo. But these are the things. It gives you a fair degree of leeway. Nothing is absolute. But certainly in this sort of weird wacko world of medico-legal, not that you want to be a recipient of it, but best to have a spine injury followed by an upper limb, followed by a lower limb, because that's the way they rank. And it's fairly black and white. So that's how we do what we do with this. Occasionally I make mental, simple arithmetic problems, but if there's, yes, that's the table we were talking about on page 25, 9 for modifiers. And once again, just because they got leg pain, say after they've had a laminectomy, or some arm pain after they've had a cervical decompression, it's not necessarily radicular. And I've been called out by some of the insurance firms over this. Well, it's not really a radiculopathy. And sometimes I'll stick to my guns, but other times I'll back down because they're correct. It doesn't make a huge difference, but since it's all, the bottom line is money and dollars and cents for these people, if they're going for WPI, every percent means something. But overall, I'm quite used to it now. I think it's a good system. I like it. I find it easy to do. And it's just the same methodology every time. And so notice it says spinal surgery, and it's different. The cervical and lumbar are more than the thoracic. You hardly ever see thoracic. You know, once in a blue moon you see a thoracic disc. Most of the thoracic stuff we see is fractures. And once again, there's ways to do it. There's guides in the guides and in the AMA guides about how to do it, and it's all to do with the how much the bone is fractured. But the overwhelming majority are lumbar, followed by cervical. Hardly anyone has thoracic problems. No, that's you. All right. Shall I tell a joke?
No. Yeah, so thank you so much, Dr. Rosenberg. It was very informative. I'm pretty sure that will be super helpful to all the case managers and our clients out there. Now, I have just one last question before we end this seminar, is that so what are the documents that you would require for these IMEs? So you could give the most accurate percentage. So MRI, CT scan, and
but basically the ones that matter most. I mean, you just want whatever radiology they've had, And, often patients forget because some of these cases have been going for years. You just want to know what they've had, and you want to know also if they've had anything that predates the injury so you can compare. Just because you've had a bit of non-specific backache in the past doesn't mean that you're a malinger and completely bunging it on now. So really, it'd be good to have as much information as possible, as opposed to, I don't try and selectively decide what legal things matter. Lawyers, case managers shouldn't decide what medical things matter, which is why often we're inundated with paperwork, most of which is not necessarily pertinent, but it's better that we get that rather than we don't receive enough. So basically, ideally reports, what also I find very helpful, because it is possible to access the majority, at least 2/3 of these ones, online digitally, so you can see the films too. So it's always nice to know where they've had it, because often in the photocopies we get, it just doesn't say, the patient doesn't know either. They say, oh, I went to Upper Kambukta West Hospital and whatever x-rays there. If it's in a public hospital, you can't access it unless you're physically in the hospital. So, just as much information as possible is the simple answer to that.
Perfect. Thank you so much, Dr. Rosenberg. That was a really, really informative presentation. Thank you so much for doing this. Thank you everyone for coming.